Well, good afternoon, everyone, and okay, and welcome to an Institute for Clinical and Translational Research enrichment series. And looks like we thought really long and hard about the title, and it looks like it worked. So we're pleased to see you, and I'm glad that you're here, because we have two absolutely wonderful speakers. We have Dr. Fadia Shaya, who is a tenured professor of pharmaceutical health services research and program chair of drugs and devices collaboration, and also is the co-director of the ICTR Informatics group. And we have Dr. Cynthia Baur, who's Endowed Professor and Director of the Horowitz Center for Health Literacy at the University of Maryland, College Park. Thank you for coming up and driving along Highway 95, 195, 295. It's always fun. Next time we'll do it on a Friday afternoon at 3 o'clock. So without further ado, standing room only, I see. That's the first time we've had an ICTR seminar where there literally is standing room only. Fadia?
Okay, thank you very much, Dr. Davis. I am delighted to be here. First, before starting, I would like to acknowledge the support of ICTR. Thank you very much for hosting this very important, I think, topic of implementation and dissemination. And I do want to introduce the team, who is our implementation team, and that would be Apurva Pradhan, Nicole Sifon, Michelle Taylor, Vanessa Michelle, Sade Jones, Yoskar Ogando, and Victoria Wolf. Please raise your hands. Okay, thank you for being here. So I would like to start here by talking about really what this is. What do you see here? Just a couple of ideas, just a couple of thoughts. This is a picture. A picture is worth 1,000 words or 1,000,000 words. What is this? Any thoughts? Okay. Okay, any thoughts? Are these drugs? Are these people? Are these, yes, over there. Building blocks of life, exactly. Okay, building blocks of life. One more thought. What is this? A caricature. This is an explosion. What, sorry? What is this? 1,000,000 candies. Somebody sees candies. Okay, it's in the eye of the beholder. Okay. So this is really what we do when we're not sure about how we are implementing our strategies. And this is what we might stand to lose also. So this is the integrity, or perhaps the waste, and you're going to see it through my presentation, the waste of our research and all the resources that we put into our research, all the brain trust that we put behind advancing science, but this is what's happening to it. And you see, this is not a random candy, this is a person. And this is what is happening to our health, presumably in the trenches. First, we had the title here, From Bench to Trench, but we changed it to data science, because it is also, these might be data bits as well. Depending where you come from, it can be candy also. So another awakening here is that we have studied often, how do we translate science to practice? And in our world, we have studied drug compliance. This is, if you put a search on Google or a search on how many compliance studies there are, as of this morning, in 0.42 seconds, there were about 380 million results on compliance. And we still have not been able to address the issues of patients at the clinical site. Compliance in diabetes, we still have interventions that are educating the patients. But is that all we need? Or do we need more of implementation and probably a rigorous science in translating what we know will favor diabetes control into the clinical practice? Why is this still a problem? And more importantly, perhaps that first picture was about the opioid overdose. In fact, just as a disclosure, it was an opioid overdose, and it is the crisis in our nation. We have grown completely We don't even hear about this anymore, the crisis, the epidemic, but this is really real. We do know that with the administration of naloxone, that might save lives. We still are not able to implement it in clinical practice or in the public health prevention networks that we have. So what is implementation science and why do we care about it? It is the study of methods to adopt and integrate evidence-based practices, but also develop them into approaches that can feed back into our practices and what we do every day. There is a gap that takes about 17 years from bench to bedside. This is not a sustainable rate of progress that we can go through. It is a difficult journey from the lab all the way to practice. It takes about, for every 100 projects here, 50 will not be published, and I'm sure some of us have gone through that. So we have many projects. 50% of my projects have not even been published. They will never make it to publication. For those out of 100, 25 are not usable or not replicable in practice, and some of them have, not mine, serious design flaws. 87% waste, and we are spending resources, so we really need to do it differently. Here, it's been called the death valleys. We know about that, but the more serious valley is here, number 2, because we have designed here, we have derived the clinical science and knowledge, but how do we translate it into practice and policy and decision making? How do we know that a rural practice knows how to and who to prescribe opioids to, when the naloxone is going to be administered? Are we using our pharmacy network properly to be able to dispense those naloxone, or are we able to reach those patients at need who will not even go into the pharmacy or not even acknowledge that they need help? So there is a real science that we have underexplored, and this is most importantly because of habit. So our muscle has been that implementation science happens on the fly, and most of the interventions have been more random, ad hoc, whereas there is a real science that needs to be grounded in that theoretical basis that we have. Again, from the publication pace, we have implementation pace here. Once we have the original research, 18% of it will not be submitted for publication. 46% of what is submitted will actually get accepted. That's another reality of how we have the generation of evidence. So this is how it's percolating. Then to publication, it takes about half a year, but there might be some publications, about 35% that lack the numbers to be disseminated into practice. Out of these, they make it into the bibliographic databases, and I know we have somebody from the library here. So by the time they get to you now, you've already wasted so much. You don't know what you don't know. Here, we have here a input of expert opinion, very important from the field, but it comes only at this stage, see? And then there's some inconsistent indexing in our systems that waste another 50%. Then, after 13 years, that evidence makes its way into reviews, guidelines, and textbooks, and finally, 9 years later into implementation. Can we sustain that level of progress when everything is moving very fast? So it takes 17 years to turn 14% of original research to the benefits of patient care. So what's the answer here? The CDC, we present, so my colleague and I, Cynthia and I, have decided to present this framework. There are others, but this is the CDC generated, the framework that looks at research phase, the translation phase, and then the institution, the phase that puts it into institutions. And it follows this process that is a cyclical process where the knowledge makes its way into the funnel, and each time, in each iteration, it gets further and further percolated and further refined. But it has to be a inclusive process where you identify the problem, adapt the knowledge to the local context. So looking at the team here, what we do in our knowledge about the prevention of opioid misuse is very different in Baltimore City than, say, on the Eastern Shore or Western Maryland. And we have to know and understand the culture and the local context, assess barriers to the knowledge, and then tailor that knowledge to monitor the use, evaluate outcomes. It's a continuous loop. And we go through that time and time again until that knowledge gets more and more refined, and finally it can make itself, its way into action and into practice. This does not have to take that long. It should not have to take 17 years when we are working in interdisciplinary way. And certainly on this campus and our, other campus, the main campuses and this campus as well, we can certainly have the brain trust and we have the energy and the interest to be working around this. So these are some of the key steps that we would follow typically in an implementation science research. We will go through the pre-implementation planning. That is very important to be able to identify the data points that we need, to identify the target population, then to look at the implementation strategy, and this is where the methods come in. And this is where we start looking at the methods, the study design, the statistics, and then we have to be set up to be able to evaluate continuously, so we go through that loop and the knowledge funnel and actually make it into practice. So we do need people who are in the practice, and we do need researchers. We need every level of input here. And this is all in the context of big data. So what is that big data? 2.5 quintillion bits of data are generated every day. I had to practice that, quintillion. This is mind-boggling. I don't even know how to interpret that. But what I know is that in 2 years, enough data have been generated to be more than all data that has been generated in the history of mankind. I repeat that. The data that has been generated in the last 2 years exceeds the amount of data that has been generated in the history of mankind. We cannot ignore that. So what data do we have here at our fingertips? At least what we have control over are data from clinical trials, primary data collection, surveys, medical records, claims, administrative claims, registries. You're all familiar with retrospective cohort studies here, registries. The FDA is collecting, realms of data with registries. And then here, the new kids on the block that I would like to also continue the conversation about. Person-generated health data. These are data that people actually post. So as we think more about how we are empowering patients, engaging patients, we are all patients of one kind or the other. We are and have the power and certainly the tools now to be able to generate our own data. That would be data that is valuable. However, so that it is not random, we need to make it into more workable files, if you will. Wearables, what are hearables? Did anybody hear about hearables? Yeah, what is a hearable?
I think it's just instead of, wearable is like a Fitbit, but then a hearable is you put it on your ear.
Yes.
And it talks to you.
It talks to you, possible. Yes, it talks to you. It can collect actually your your data. And there's a lot of talk now about the next year or two being the era of hearables, not only wearables, but hearables where you get your temperature, consistently monitor your pulse, etc. That's an interesting topic, but certainly this is not science fiction. So it is coming through. Elon Musk with the neural link. Has anybody linked to OpenAI? Anybody heard about that? So this is actually under consideration by the FDA as a medical device. Small filament that will go in your brain. So what is healthcare data, and where do healthcare data fall into that 2.5 quintillion data that are generated every day? Actually, the amount of growth, the rate of growth in healthcare data exceeds that of the manufacturing industry, no matter what you think, and financial services, and even media and entertainment. So the rate of growth of our healthcare data is 36% through 2025. That is something to at least be paying attention to as we think how to translate all the important research that we do, that 87% of it is getting wasted, taking 17 years. How can we leverage that? Person-generated data, I talked about that. These can supplement clinical data. And again, this is really only about showing you what is available out there. This is not to go into depth, but we're very happy to have that continuing conversation. The other type of data that is really now being extremely highlighted is the data on social determinants of health. And these are getting more standardized, if you will. There is a framework that's being developed. It's making its way into the EHR. So you would be asked about your experience with violence on day-to-day, about potential adverse childhood experiences. These are making their way into your intake forms. They're going into your EHR. Something about disruption of family, unemployment. Again, this is all so that it can inform a better picture of the overall person, as opposed to only replicating perhaps only that clinical, because it is important. We have seen that in the non-compliance rates, et cetera. So what are the documents currently that are available? We have certainly the reviews. We have the Cochrane reviews. Many of us are familiar with that. But if you look at this in the context of practice, how can an internist keep up with, just to keep up, just to stay current, not be ahead, just to stay current, reading 34 primary literature articles a day? I mean, it's not possible. And today it's 34, maybe tomorrow it's 35 or more. So this is not really sustainable. And if you think about that, also there's that pyramid of hierarchy, if you will, with the evidence or the quality of the evidence that we have in the literature. So here at the very bottom, it's expert opinion. It's the one and of one case reports, then case control studies. At the very top here, we start approaching more pure level of evidence, randomized clinical trials, systematic and meta-analyses. But all of these are still very difficult to apply in practice. And that's where we need that more methods. And this is where I'm happy that we have this discussion to see how best to move this forward. As an example here, I look at and I show quality indicators. They have been developed over many years for the management of chronic diseases. But if you look here at how, you know, they call it pass rate. I don't like that word, but that's what they called it. And it shows the percent of people who received the care out of those who needed it based on the quality indicators. And you see here, for osteoarthritis, a very prevalent condition, typically with people who have other comorbidities perhaps, or co-medications, the rate is only between 29 and 31%. Bad, good, we don't know. We really don't know, because this is really based on the judgment at the clinical interface. But we don't have a means, at least, to translate that information at the front lines. The difference between here, I would like you to have the slide when you get these, the difference between clinical research and implementation is that it does start with clinical research, but then we have to move into the strategy of implementation and look at outcomes beyond and past, once we have the health outcomes, look at the adoption rates, adherence to medication, or fidelity of the intervention. These are examples of actual implementation studies that have been funded by NCATS. And I will just look at here, for example, here the implementation to ensure consistent delivery of a pharmacy service for an at-home patient population. This has not been funded by NCAS. This is a study we had done where we had actually seeded social networks to propagate different interventions through social networks, friends of friends of friends, because we built it on the trust, inter-person trust. So I would like to segue now to the dissemination part, but with that, I would like to say that we could be discussing plans of innovation and implementation science interest groups for those who need it, who are interested. Everybody needs it, but for those who are interested, and possibly building an ecosystem of agile implementation. We would like now to move from implementation to dissemination. So please. And this is your report. Okay. So.
Okay, well, thank you. As you heard in the introduction, I'm Cynthia Baur. I'm from down the road in College Park. And we have a Center for Health Literacy. And when you hear the term health literacy, you're probably thinking the public, consumers, patients, clients. But health literacy actually has a lot to do with all of you in the room. And when we talk about health literacy, we're really talking about what do we do as professionals to make it easier for many different groups of people to understand and use the information that we generate. So you heard from Fadia about this, like Niagara Falls of information or data that we're all drowning under. And you may be thinking, well, I'm just a clinician trying to get going in research, or I am a researcher and I'm just trying to figure out how to get my study published, or I'm trying to figure out how to get somebody to use my results. So what do I do? So my slides, I'm not going to go into a lot of detail about them, but they're really going to be a reference for you. There are a series of questions that you can ask as you think about the dissemination process. What Fadia and I decided is that we would each do a brief presentation, but at the end we would leave time for her to show you some things on the center's website that could be very useful resources for you as a follow-up. So one of the things that I wake up every day thinking about is attention, right? I am a realist about people's attention. You know, even the structure of you sitting here for an hour for this talk is a little bit artificial, because I talk to undergraduates a lot, and holding their attention for an hour is getting really, really challenging. You know, they're looking at their watch. If I let them have their phones, they're definitely looking at their phones or their, you know, laptops if they have them. So I'm very mindful that attention is a scarce resource in our society. And I would strongly encourage you to think about your dissemination efforts from that perspective, that you love your topic. That's why you do it. If you're a clinician, you love your patients, you love the patient care that you do. If you're a researcher, you love the topic that you do. So before I came to College Park 3 years ago, I spent 10 years in Atlanta at CDC leading the health literacy and plain language work there. So I dealt with a wide range of researchers for those 10 years, and all of them love their topic. They are absolutely positively convinced that everybody needs to know what they know about West Nile, about diabetes, about asthma, about you name it, because they are completely immersed in their topic. And that's great. We need that level of expertise. But the people that you're trying to reach, who are going to use that information, they don't need that same level usually. And that's what we're going to talk about today. So who can use my results? Tips to design for dissemination. And so when Fadia and I were talking about this, I said the main point that I really wanted to get across with my talk is that you have to think about dissemination at the same time you are thinking about your study design. When you're thinking about what is my question, you should be asking who's going to use what I might find out. It doesn't matter what you might find out, but you need to think from the beginning who might actually use what I could find out. So just a reminder about what dissemination is. It can be for public health or clinical audiences. It can be about information or intervention materials. So it can just be a description of your study or your findings, but it can also be about an intervention. It's usually going to involve some kind of targeted distribution. You're going to have to know who needs to use your results. What you're hoping is not just to have a one-time only exposure to this. What you're hoping is to spread and sustain this knowledge and these interventions over time. So as I said, I really want you to think about dissemination as happening at the beginning, about starting with this question, who can use my results and why? So when I talk about this from a communication perspective, I'm using the terms audience, who's your audience? And I'm talking about your communication objective or purpose. So why is it important for somebody to know what you know? And we don't often stop and think about this. We just assume that people should want to know what we know, because again, we're infinitely interested in what we know. But what I'm asking you to think about is to think about that other, right? So when we teach plain language classes, we talk about I-focused communication, which is what do I know, what do I want to say, what is in my interest, versus you or audience-centered communication. Who are you? What do you want to know? How can I give you something that would be useful? So it's really flipping that and saying not so much about this ego kind of driven perspective, but more about you and who are you and what do you need. So it can inform the research questions themselves. It can inform who you choose to include in your study populations and the settings. So for example, if you could design the most perfect study, but if you can't figure out how that's going to work in clinical practice, again, that's going to go back to what Fadia was saying in terms of how much research is actually wasted because we can't figure out how to use it. So thinking about those study populations and settings right from the beginning. And then what would be your sequencing, right? So yes, you're very focused on this one study or this one project right now, but what's going to be your sequence? So I'll give you an example. We're funded right now to build a smartphone application for prevention information that's built on the U.S. Preventive Services Task Force recommendations. So it's consumer information that aligns with those recommendations. That's a translation activity, right? Because I guarantee you consumers are not actively going and looking for the U.S. Preventive Services Task Force guidelines because number one, they don't know they exist, and number two, their web pages don't work very well for consumers. I was going to be less polite, but that was the polite version. So what we're thinking about is, yes, we're building this smartphone application now because we're getting funded to do it, but we're thinking about the second and the third and the fourth studies that we're going to do from that because we see there's many different audiences that could use the smartphone app. There's many additional kinds of information that we can incorporate. There's many different kinds of settings where this app could be useful. So really thinking about that from the beginning. And then it can also help inform your analytical plans. Again, back to the point of, yes, you can generate a ton of data, but who's going to use it? So your analytical plan might actually be influenced by dissemination. And then, of course, what we often think about is, how do I present my results, right? Thinking about your abstract, your conference presentation, talks like this. But, you know, that's kind of the tail end of the process, not the beginning. And then hopefully they will get translated into a program or intervention. So I'm going to just kind of quickly run through these. Like I said, you'll have these slides. There'll be a series of questions that you can use in the future. But when you think about your audience, again, why do they need this information or materials? How will they actually use them? Sitting there and thinking about that process. So if we were to draw a logic model, which, you know, if you've had any interaction with CDC, you know a lot about using logic models and how much they love logic models. If you think about it, the logic model is supposed to flow left to right. But if you're thinking about implementation and dissemination, you actually start on the right side and work right to left. Because that right side represents what's going to happen in the long term, right? The outcomes. That's the far right side of a logic model, is that outcomes column. And that's divided into short, medium, and long-term outcomes. If you start on the right side of a logic model and work back, you're going to be thinking about this use question from the beginning, right? Because you're thinking about setting, you're thinking about audience, you're thinking about all those things that people will do with the data. Fadia mentioned social networks. That's an issue of trust, right? Thinking about who's going to trust. So I can give presentations all day long, but that doesn't mean I'm necessarily going to be a trusted source of information for every single audience. So really thinking about trust from the beginning. And how do people find and get information? You know, my CDC colleagues, that one of their favorite things was to create toolkits for clinicians. They were absolutely convinced that clinicians wanted toolkits. But yet, the evidence showed that when you went into people's offices and practices, those toolkits were sitting on shelves that people actually knew where they were, right? So clinicians were getting inundated by these toolkits because people were not thinking about how they actually find and get information and materials. So again, what kinds of materials are going to be useful? Should you deliver it through their phone? Should you deliver it through a lunchtime brown bag talk? Should you deliver it through a grand rounds? Should it be in a scientific journal? These are all options for disseminating information. But again, if you're thinking about the audience, what's easiest for that audience to use? Are they going to be an audience that understands your jargon? As we work increasingly in a team-based environment, the language that you may speak as a specialist in one area, just because somebody else also has an MD or a PhD or a whole bunch of other letters after their name, doesn't mean they're going to understand the same language that you do. They've been trained differently, they read different journals, they might use different methods, so it can still count as jargon when you're trying to do that cross-expert discussion. Do people need guides or directions for use? We often forget that people need directions for something new. yesterday, my smartphone team, we were sitting there talking about how we're actually going to get this app downloaded on our study participants' phones and what kind of directions we're going to give them to take home. Because even if we give them this in-person training session, which is what we're talking about, we want them to sustain the use of this app. So what kind of supportive materials are they going to need to not just use the app in our session, but continue to use it over the course of the study? Well, they need training, refreshers, advanced help. These are all things to think about in terms of the supportive materials. So again, you got your data, you got your project, but how are people going to sustain this over time? The biggest myth that people have is that their audience is everyone. One of the examples I like to use is, parents. Parents are often like, if you think about clinicians, right? A lot of times parents are going to be their target audience, even if they're not pediatricians, right? Because people are bringing in their kids for lots of different things to primary care. But, my daughter is almost 25 at this point, and she doesn't let me make many, if any, healthcare decisions for her anymore. But that wasn't true when she was a baby, right? I was responsible for all those healthcare decisions. So if you said that your ultimate end user of this information that you're generating were parents, that's not quite true, because I am a parent, but I'm probably not your target audience if, for example, what you're trying to do is figure out how to increase well baby visits and vaccination rates for early childhood vaccinations, because I passed that stage 25 years ago, right? So you need to think about really who your audience is like even parents, you might think, oh, that's kind of, being pretty specific. But actually what you really need to get down to is it's parents of young children coming in for well baby visits who are not following the vaccination schedule. That is a target audience. So as I said, name them in detail. For example, are we really talking about clinicians? Are we talking about cardiologists? Or are we talking about cardiologists who treat patients who have housing or food insecurity problems, right? That's not your Beverly Hills cardiologist, probably. That's a cardiologist practicing in a very different social context. If you think about, you're doing a study on blood pressure, how might those results need to be made meaningful if, again, it's these clinicians and patients working in a scarce resource environment and your recommendations require like housing and food security to be sort of an underlying assumption, right? If your recommendations have to do with diet, for example, and somebody's dealing with food insecurity, how likely are they going to be able to use your results? And you have to think about where people are most likely to see, hear, or be exposed to your information. As I said, I think a lot of that attention, cognitive scientists will tell you we spend almost all of our waking hours using mental models or heuristics to very quickly process information in as little time as possible. We reserve our in-depth attention for very specific circumstances. And so you have to think about this issue of how much attention people are going to, you say, well, I put it up there, I put it on our website, I sent it out through social media, I did this, I did that. That doesn't mean people are actually exposed because they might not be paying attention. One of the things we don't do often enough is think about the scale. We think, oh, well, we did this study in this population and we got these results. Or we're, if we're doing clinical work, we're thinking about, well, this is my patient panel. But you got to think about scale, right? So what works with one particular group might not work with every other group. So how are you going to reach enough of those people, and how might you reach different groups of people? So again, thinking of that from the beginning. And what will really motivate people, and what incentives do they have to use? So I try and do health literacy interventions for clinicians. And so one of the things I hear all the time from clinicians is, you don't pay me to talk to patients, and I don't have time. I hear that all the time. Those are the two barriers to get clinicians to be better communicators. You don't pay me and I don't have time. So I have to think about what other kinds of incentives could be leveraged to get clinicians to care about improving their communication with patients. That's just a reality of the work that I do. And if you don't think about incentives, you're probably not going to have a very successful dissemination process. So, these are some of the motivations I think about. facilities have to get accredited. So maybe if the hospital they work in cares about better communication as part of the accreditation process, maybe that's an incentive or a leverage point. Maybe they're being paid based on quality measures and they're not calling that communication, but that could be a leverage point. Again, maybe they're getting paid based on the survey results, the patient satisfaction survey results that are coming back. Maybe there's a program manager who set some program objectives that I could leverage to get their attention to adopt my recommendations on health literacy. Increasingly, people are being asked to think about population health outcomes as opposed to individual patient results. So maybe that's a leverage point to get them to adopt my intervention. And hopefully, every once in a while, I try and appeal to their, better angels and say, actually, we have an ethical commitment to provide the best quality care and to design ethical studies, and thinking about health literacy and communication issues as part of being an ethical researcher and clinician. So there's many, many ways that we communicate research information. We do a lot of it in text, right? We are highly educated people. We're extremely comfortable processing large amounts of information, and so we're very comfortable with text. We also use a lot of numbers, of course, because we generate a lot of data. But we also are increasingly using images to convey our information, and we are in an image-driven society with things like Instagram and other social media channels where people expect visual information to be more available. You're seeing more and more use of videos to convey information, and of course people communicate orally, and then we use graphs, tables, and forms to communicate our data. So I just want you to kind of think expansively. You think, oh yes, I wrote my journal article, my journal article has a couple of graphs or tables in it, or I did my conference presentation, but you really have a very large universe of channels to think about when you think about disseminating information, but it goes back to who? Where do they get their information? What gets their attention? Where are they regularly going? Don't force somebody to go somewhere they're not already going. I guarantee you, you will waste a ton of resources doing that. So I want to just wrap up here with one dissemination example. We're currently working on trying to understand why people do and don't complete the National Diabetes Prevention Program. So the NDPP is, an evidence-based program. There's been a lot of resources, as Fadia said, invested in the research to say the NDPP is an evidence-based program. It is designed to be a 12-month program with specific benchmarks that, in terms of weight loss. So what might be the obvious dissemination challenges with a program like that? What's that? Why is it hard?
Hard to change your exercise and eating behavior.
Yeah, and especially over 12 months, to be in a program for 12 months, right? How many people have a gym membership that they've maintained forever, and maybe they go how many times a year, right? How many people have started a diet at the beginning of the year and lasted longer than 30 days, right? So 12 months, this program is evidence-based, but it's based on a 12-month commitment. And of course, it's not surprising that a lot of people have a big challenge actually completing the program. So what we've been engaged to do is really understand what is going on. There are some people who love the program. We've interviewed many people. We've done focus groups that people said, I love the program. In fact, I want to take it again, and I have taken it again. There are people who take the program multiple times. They like it so much. They find a lot of value in the social support they get from the DPP. But there's a lot of other people who either start and drop out, don't follow the clinician's recommendation, or never even consider it. And so again, this is an issue. You've got a very sound program with a lot of evidence behind it, but what we're really struggling as a country is we're having a hard time getting people in this program and completing it, even though we know that it can produce the results that we want. So this is an example of, I think, designing a program that probably is not a great fit with people's lifestyle. I'm just going to put a little plug in for something that we're going to be doing, my center is going to be doing here with Baltimore this summer and the year beyond, is we're going to be working with a group of students from the Baltimore campus on an Empower project and looking at health literacy as part of professional education here on the campus. So we're going to have a team of Empower Summer Scholars. They're going to be looking at team-based education and training in health literacy, and then that's going to carry over into something called the University or UMB President's White Paper, and looking at health literacy as a social determinant of health. And UMB students will be recommending actions that the university can take to address health literacy as a social determinant. So thank you, and I think we want to then have some questions, and you want to show a little bit about your website, right?
Yeah, Wes. Yeah, thank you. Perhaps for the time that we have here, a few minutes, I would like to be sure we have time for questions. And also, if you don't have questions, I would like also to hear from you about what is your experience with implementation science or de-implementation science. That's another thing we didn't talk about. How do you stop doing something that you know doesn't work? But in your context, is there a specific clinical area that you're having trouble with, or any, any method? Or I'll tell you what my challenge is translating those into actual data, because what gets measured gets done. And my challenge in the research is how to be able to capture the elements that we said are important in implementation science into data that we can then put into models and then measure outcomes of. But any thought from those who work with data, or those who work with perhaps difficult to reach populations, or where you have seen a gap in implementation, I would love to hear from you. Anybody working in chronic conditions, or we are considering, so I would put people here with the HRT on the spot. I didn't tell you this, but we are working on potential implementation of certain programs for the prevention of opioid misuse and abuse. And as long as we have been working in the communities, what we have not considered are the overall deprivation measures in certain communities. So certain housing insecurity, or food insecurity, or adverse childhood experiences that matter at the community level, and no longer taking individuals one-on-one, but also looking at the overall impact of what measures in the community or social determinants of health are impacting their adoption of those prevention methods. So Michelle or Nicole or Sharday or Apurva, if you want to say anything about that, the microphone is yours now. This is your time to be saying something, or this is something we're going to be working on. Anyone else? Okay. We can actually, I see that we are coming to the, we have one question.
I apologize for arriving late. I do wear a couple of hats. One is I'm a neurologist. I'm currently dividing my time between the Baltimore VA GRAC, and I have a faculty appointment at Hopkins and an adjunct here at Maryland. So,
and you're Dr. Beth Hogan.
I'm Dr. Beth Hogan.
Yes.
I have worked, I worked for 3 years for MedStar before coming here. So I know the MedConnect EHR, and I worked also, we rotated at St. Joe's, so I'm familiar with Epic. And in one of my previous lives, I studied a medical student development. So I have a paper called Formative Experiences of Emerging Physicians. So kind of talking about what are those life experiences for physicians. And so I was, I guess, struck by your comments about how hard it is to get physicians to change behavior. And wanted to offer a suggestion that all medical students go into medicine because they want to be great doctors, not because they want to click 1,000 times a day. And most of the clinicians I know right now are up from 11 at night till 1:30 in the morning finishing their charting. And so there is a huge burden. I mean, if you're up till 1:30 at night, it's because you're writing a grant and you have these kind of aspirationals or inspirational goals. And nobody aspires to be, you know, writing medical charts at 1:30 at night after they put their kids to bed. That's just not what people wanted to do. They really do want to be great doctors. And so I think if there's a way to bring, you know, communication and health literacy in a way that taps into that kind of, you talked about the ethical part, right, which we think of as ethos. My 13-year-old is analyzing the speech of Mark Antony. There's a logical reasoning, but I also want to encourage you to tap into the pathos, like those kind of social, emotional goals of physicians themselves, and kind of link your desire to educate around health literacy into who they want to be, which is they all want to be great doctors at the end of the day.
Yeah, thank you. I'm just going to, yeah, I'm sure maybe you want to, and we all aspire to certainly, support that. And that's why we need those conversations. I'm glad to, thank you for your comment.
Thank you for the comment. I was just sitting silent. We just did a survey on, so I'm a clinician. I didn't get offended from your comment.
Do you want to introduce yourself?
I'm Ash Sachdeva.
Okay.
I head the interventional pulmonary program here. And we are a very young specialty. We just ran a survey to all the physicians who practice the same specialty as I do. And we got a result that 40% are probably happy with what they're doing, which means that you have a workforce that is 5-7 years into finishing a fellowship, and they are just probably happy, which means a downward trend. So I agree. I think when the fact somebody's saying that I don't have time is not a reflection of they don't have time. It's a reflection of the well-being of that individual not being cared for, because the administrators keep putting added requests. And I think they use and I think it's well published in New York Times, the context is always that you are trained to take care of patients. That's an ethical concern. And we all come from the background that we care for people. And that actually leads to a burnt out phase after initial rise. You know, you work hard, 5 years, 7 years, and then you see that it's draining you emotionally. You have to take care of your family. And then you go to that decline phase. That is when you start saying, I don't know, I don't have time. And I don't think that's coming from the place people are, but it's coming from a very dysfunctional state that nobody's recognizing.
Yeah, I think those are all good points. I mean, what I try and do, I mean, if I were talking about, if this were the main topic in terms of like clinicians and communication, I mean, my basic pitch is whether you spend 3 minutes, 5 minutes, 7 minutes, 10 minutes, 12 minutes, 20 minutes, 60 minutes talking to a patient, whatever the length of time is, we have evidence-based techniques to make that the most effective 3 minutes, 5 minutes, 7 minutes, 60 minutes. The challenge is that I find is that, you know, as a PhD, I came up through the medieval guild system too, right? I had a dissertation advisor, I had a committee, they ran my life until they gave me my degree, blah, 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 right? I mean, we all come up through these, you know, very hierarchical systems. And I think one of the challenges is that we hear is that, you know, in terms of the mentorship, a lot of the longer term practicing clinicians, maybe they haven't had, maybe they've sort of gone through that trough back up again, but they're not being mentored. The younger physicians are, and nursing students and pharmacists are not necessarily being mentored to value good communication either. So I think there's a lot of different reasons. I think there's interpersonal reasons. I think there's structural reasons. I think there's mentorship reasons. I think there's a whole bunch of constellation of reasons about why it's challenging to get communication interventions adopted. But I do think that the reality is we live in a system of not only what gets measured gets done, but what gets paid for gets done. And I think as we increasingly shift towards some of those other metrics that I was talking about, maybe communication has a chance to get paid for under some of those frameworks, like under a population health framework or more value on patient satisfaction measures and things like that.
Yeah, thank you. I'm just going to put my plug for data is key. So anything that we can translate into measurable data or data, it would be very important. And remember, patients are also generating information, and patients are active, or persons are active participants in the generation of that evidence and in our whole conversation. So please.
I just wanted to represent the social scientists in the room who don't do medical research. Is this on? Can you hear me? So I'm Dr. Margaret Candelaria. I'm on faculty in the School of Social Work. I have several social work colleagues here. We actually are at the Institute for Innovation and Implementation, and we do primarily implementation research around behavioral health, children's mental health and behavioral health practices. And we actually convened a small group of cross-campus implementation researchers yesterday, not really knowing that you have all this going on. So I just would love to do more intentional connection, because we often feel like the very heavy medical language doesn't reflect what we're doing, implementing EBPs with kids and families and community agencies. It's not, as medically driven, but the same concepts.
Okay, so thank you for sharing this. The intent of this was really, no pun intended, but check the pulse and see what the interest is in the topic, and certainly start the conversation. Thank you for sharing. And I think we're coming to the end of, so Dr. Davis, one more? One more, but I will give it.
So what I'm going to say, thank you. And Fadia, would you like to give a quick overview of the informatics core of the ICTR, just so that people can understand a little bit more of what we provide?
Yes, sure. So yes, thank you, Dr. Davis. So what, as you know, the ICTR is that whole infrastructure grant, and the informatics core, in fact, is a common denominator across all the cores, and it includes a focus on electronic health records, retrospective databases, digital health, social determinants of health, and currently we are also working with artificial intelligence and machine learning to see how best to fuel that process by utilizing the data. So there's a big link with the discussion today as we think about how to implement the science and translate it into practice. It is really all based on data. Whether you think about data in terms of text, or data in terms of what's leveraged from the EHR, or data from patient-generated health information, or well, my favorite now is the hearables, if you can hear me say that. But really it is about the data. And the informatics core is the home of that. We work collaboratively with Johns Hopkins Informatics Core, and we are developing further methods to leveraging electronic health records, because that is really what is reflecting with the best fidelity that we have available now, the clinical encounter. So I think that's in a nutshell. And certainly with the ICTR, you have access to the ICTR website. We do provide information on, we do provide services on supporting you in your research. And so there is a process. You go on the website, you log in your research proposal, and we will provide the services depending on your need. We are available also on the heels of this presentation to be discussing with you your thoughts about your implementation science project or your research. The most important part here, as we mentioned, is to start with the proper design. Because many people come to the informatics core and they say, we want this data. And then when we delve deeper into the question, we say, well, wait a minute, are you sure you want that type of data? Why aren't you requesting that? We have this available also. So we want to take it one step earlier and discuss with you your needs, your study design in terms of what data needs are, and then advise you accordingly. So I think this is in a nutshell the services we provide. We're certainly trying to expand them with more focus on the implementation side of how do you see your study results being implemented, and then advise you and help you and support you earlier in the process as you request your data. It is really a fascinating world. I mean, I started with data, then went all the way working in the community, went back to data. This is really, for me, at the end of the day, it is the North Star, because this is where you actually can move your research. And that's my opinion, my unbiased opinion. Do we have time? I just want to be sure we have time. I have time, but maybe this, no, please ask the question. And then what we'll do is we stop so people, you know, in the, what's that, respect of people's time, and then we can take questions here. But please go ahead and ask your question.
Yeah, so my name is Minhaj Siddiqui. I'm a urologist. I specialize in urologic oncology. And so, you know, my only thing was, you know, I do a lot of clinical research. I have like particular like focus area that, you know, I've spent a lot of time doing work in. And so I think, you know, my area is prostate cancer and MRIs, for example. And so I have a lot of ideas on like how it should be applied in a general audience, but then the idea of like doing like a formal implementation project and figuring out how to get that process even started, let alone kind of up and going, is daunting because I have no background in this.
Okay, I think we have a request. Dieter, or, okay. So
The
let's,
question is really like, you know, for like people like, and I suspect a lot of my colleagues, you know, in the medical center at least side, kind of a similar type of situation that we're all trained in how to do clinical research. How do we effectively collaborate with you? You know, what are things, you know, you've collaborated with a lot of people, and so you probably have seen things that work and things that don't work, and it'd be great to hear like, you know, who are the people that come into this and are successful, and what do they bring often that makes them successful?
well, that's exactly the purpose of this, to get this started, gauge the interest, and follow up on it. Okay. In the interest of time, I just want to be sure that you want to, okay. So I guess, Dr. Davis, did you want to close officially the session? Okay, well, thank you very much for attending. We have your names. We know where you live. We will be in touch, you know, to see who might be interested in following the conversation. Thank you.